Welcome to the Beyond Biopsychosocial Training Program. My name is Jeff Hauk, and I want to acknowledge my co-authors, Dr. Kang, Philbrook, Jacobson, and Cuddyford. This particular module focuses in on satisfaction with participation in social roles and activities. The module is divided into 3 sections, focusing on motivations for including this scale, basics of interpreting this particular scale, and then finally application to clinical practice. The importance of social and person-centered goals really surprised us. We're used to setting functional goals in an efficient manner clinically. As we explored psychological theories that focus in on satisfaction with social roles in family, friends, work, and leisure as a consequence of values and identity, self-regulation, self-efficacy, and motivations, we realized that essentially person-centered social goals are the heart of therapeutic alliance, and this struck us like a sledgehammer. When we explore social cognitive theory, what we find is that it's well represented in physical therapy literature. Low back pain, cancer, Parkinson's disease, muscular sclerosis, and geriatric care, among others. And what we realize in social cognitive theory is the focus on the person and their social and life choices is really at the heart, motivating them and cementing their commitment to physical therapy and lifestyle changes. Social cognitive theory is helpful. It points us to outcomes expectations, social structural factors, and low self-efficacy as possible reasons patients may have difficulty defining goals. It also directs us to explore these variables using psychological approaches to light a spark of hope by setting goals that match the patient's readiness or confidence to move forward. Our ability to navigate these variables as we challenge patients physically, helping them reach their goals, is a critical element of the therapeutic alliance. What we are learning is that social, person-centered goals are essential for a strong therapeutic alliance, and that patients will work hard and remain committed to goals that are meaningful to them and that they are confident enough to work toward. And that social, person-centered goals change over the course of care because patients' beliefs change, their outcomes expectations change, and their barriers and facilitators change. So there's an advantage to using the PROMIS Satisfaction with Participation in Social Roles and Activities measure. It gives us a look at how patients are integrating these changes in beliefs, outcomes, expectations, and facilitators with their satisfaction in their social role in life. So that concludes the motivation section. So let's move on to the basics of interpreting this scale. This measure assesses satisfaction with performing one's usual social roles and activities with respect to family, friends, work, and leisure. Items might include, I am satisfied with my ability to do regular personal and household responsibilities, or I am satisfied with my ability to work, or I am satisfied with my ability to participate in family activities. And each one of these items then is scored on a Likert scale that varies from not at all to very much. Further details of this computer adaptive algorithm are that it includes 44 items. 4 items is usually sufficient to obtain a T-score, and the reference population is the US average. But remember, the measure is about social function with respect to family, friends, work, and leisure. So the T-score of 50 and standard deviation of 10 still stands. We have very little data for this particular PROMIS measure because we only started collecting this on all patients recently. So here we're showing you 2 different samples. A sample from a local rec center in light blue and a sample from our clinic in dark blue. You can see that there's about a half standard deviation difference between the 2 samples, and that essentially all of the GFU clinic data is below 50 except for a few patients. Floor effects on this scale are 25. Ceiling effects are 68, giving it a really wide range. Similar to the self-efficacy of symptom management scale, the satisfaction with participation in social roles and activity categories include low to high, where above 60 is high or very high, 40 to 60 is average, and below 40 is low to very low. And so the patient we see here that has a satisfaction with participation in social roles score of 42 would be considered average. Minimal clinically important differences are not studied thoroughly for this scale as of yet. However, a half standard deviation score likely applies. And there are no known important benchmarks, although a half standard deviation below the US average is an initial guess. To get a detailed look at what a low t-score would mean, let's use an example of a 35. A person with this low of a t-score is not at all satisfied with daily routines and ability to work. And they're just a little bit satisfied with ability to meet the needs of people who depend on them and the ability to do regular personal and household responsibilities. Now let's contrast this with an average score. In this case, they're satisfied a little bit with daily routines and somewhat with ability to work. And they're somewhat satisfied with how much work they can do and a little bit satisfied with their ability to do regular personal and household responsibilities. This gives us a pretty good sense that family, friends, work, and leisure social activities are impacting patients when these scores are low. So that covers motivations and basics. So now let's move on to application to clinical practice. So let's start with a case we're familiar with. If you recall, Cliff had a myocardial infarction and had refused to attend cardiac rehab. So the doctor called physical therapy and asked him to initiate cardiac rehab with this patient. And we note the PROMIS scores here were remarkably low and the fatigue score extremely high and self-efficacy 2 standard deviations lower than normal. And on the first visit, this person's performance was 2 minutes on a treadmill at 0% incline at around 0.7 miles per hour. Note that also the EKG readings were normal and cardiovascular responses were as expected. Given this starting point, setting goals seems to be a difficult task. So the initial goals were just to attend cardiac rehab, get the patient to express confidence in their heart's ability to recover, and then to build self-efficacy and physical abilities. Now, the patient expresses confidence in performing daily tasks, and this might include sit-to-stand, household and community ambulation, and self-report of participation in household chores. The hope is that these low-level goals would spark higher, more ambitious goals as the patient progressed. The second phase of goal setting became much more social, where the patient identified attending his aunt's birthday party was significant to him and required him to travel independently by plane. Functional goals that were required to do this were walk independently to the gate managing luggage and to be able to manage luggage in the car and through security. And a second high-end goal was to attend sporting events. Before retirement, this patient was a sports rider and still held a strong desire to participate in his former occupation. So those goals had to do with ambulating independently in crowded environments and to be able to take flights of stairs so that he could pick the seats he wanted. Let's listen to the patient and provider reflect on goal setting throughout their process of care. So, I mean, that's a pretty complex eval.
Yep.
And then overlaying some of this kind of psychosocial components. Was that kind of part of each testing procedure too? Is that how?
Yeah, so when I start, it's interesting. We always do pre-vitals, so our vitals when they first come in, and we run a resting EKG. And I would tell you that that is gives a patient a lot of confidence in you if you're very technical with them and you're running a 12 lead or you're just running EKG with them. And so ECKG was fine, and so that allowed us to then recognize that his vitals were fine. And and then I kind of told him what to expect when we're doing the great exercise testing.
Mm-hmm.
And then he had some way of being able to communicate back with me using the RPE scale.
Okay.
So I put these frameworks, this technical biological frameworks in place.
So what I'm hearing is when you made it clear that you were really open to him.
Yep.
And listening to him, and you even discounted the goals from PT at some level.
Yeah.
Then he opened up to you differently.
Oh yeah, I mean he opened up so much he couldn't. He was you can see he captured his imagination. He was like, so you're telling me that I can fly again? So you're telling me that I can go see my aunt, right? Mm-hmm. You're telling me that that I can go see a football game. But this is the really cool thing. But you can make some really great physical therapy goals from a patient or a person-centered goal. Right. So one of the things was to climb stairs together. Mm-hmm. Right. Do step-ups. Right. It was to practice, dragging a piece of luggage while he was here. Right. So he brought his luggage and we had him drag it around while he was doing the 3-minute or 6-minute walk test. Right.
It all started when I had a heart attack and an operation, and I was pretty much a zombie. I had really no idea what I should do to prove myself, and I get a call from this Dan King. Who's that? But anyway, I originally intended to just blow it off, and just like I do everything like that, but somehow it's just your voice. It was just a lot of warmth and confidence, and it just kind of stuck with me. So I said, well, I'll give him a call at least. Mm-hmm. And then next I decided I'd go once. And I just kept going from there. And I just kept making improvement, and it was the best thing I could have done.
Did you have any goals that you wanted to accomplish during your time here?
I had no goals when I started. I just my only goal was to get out of here as soon as possible. Of course, that didn't happen, fortunately.
Yeah.
And I got my goals, my kind of vision of what I wanted to be, the more I proceeded with the program.
Yeah. And would you say you've accomplished a lot of your goals that you wanted for yourself?
I say I'd far exceeded them. Yeah.
So prior to coming to physical therapy for your heart, how was your attitude towards exercise and your lifestyle?
My attitude was put it off as long as possible, indefinitely, if you can. So I just reached a stage where when you're young, you just have that animal urge to play sports and do things, and it's fun.
Yep.
And then as you get older, past 40 and on, you lose that desire and the fun, and it just becomes effort and not enjoyment.
Yeah.
And that's where I was stuck before I came here.
So kind of tell me about the gains that you think people will receive coming physical therapy. What kind of gains do you think?
Well, I think just what I did, just every way you'll be gradually lifted up. Your doubts and inertia will be overcome, and you'll slowly get better in every way. And then who knows what could happen from there.
So Cliff's story is remarkable, looking at his PROMIS scores and listening to him and Dr. Kang discuss his case. Essentially, his PROMIS scores in physical function improved into the mild limitations range. His fatigue score was just at the cusp of clinically significant, and his self-efficacy was average. In addition, his measured performance reached the 5 to 6 MET range. Notice that in the discussions, the PROMIS measure was helpful for understanding how goals that we were interested in, but the actual goals remained more functionally based and meaningful to him in terms of attending his aunt's event or going to a football game. Those were more meaningful to him than the PROMIS scales. So just a word of caution that the PROMIS scales are important to us as therapists to understand how our different psychological and physical approaches are affecting patients, but they don't replace the meaningful social goals that are person-centered, that are identified by the patient. So let's listen to Joni's case as well. And if you recall, she's a 64-year-old female that had both recurrent low back pain, 8 months following lumbar surgery, and also cancer-associated fatigue. Her PROMIS scores helped us zero in on the high fatigue as the primary problem. And this was matched with performance-based testing and interviews which identified that her peak activity throughout the week was less than 3 meds. Let's listen to Joni and her husband Paul reflect on the process of reestablishing physical ability while dealing with cancer-associated fatigue and her low back limitations.
Well, another thing that it really hindered was my relationship with being able to interact with my grandkids, my small grandkids. My activity level was very limited. I couldn't lift them. I wouldn't be able to be as involved or as active, and I think it does affect my identity in that way, even as a wife, because even now, I mean, I don't cook, but mostly he's a better cook than me. But
You do fine.
I could do fine.
And you have. Actually, you have. In the last few months, you've been cooking more.
Yeah, and I've been doing more around the house.
Mhm.
Makes me feel better. It's part of the identity thing.
Right.
And when you can't do those things, it really does, kind of make you feel less valuable. Or, So, not that he would ever make me feel that way or anybody else. It's just, it's part of the identity, I guess. And but you can't do those things.
Yeah. One of the things that I see also is that you're getting more involved than you have been. There have been, several months ago, there'd be days that you would stay in bed, and now you're up every day, doing things. You're involved in your painting classes. You're involved in piano. You're involved in all kinds of different things. So overall, there are other things that are going on too. So.
Yeah.
I'm making some specific choices to build some talents, especially with upcoming treatment that I'll be having. Mostly, we went everywhere and went up and down a lot of castle steps and abbeys and wow.
Amazing.
Yeah. A nice hike up a river gorge.
Yeah.
They're beautiful. Yeah.
That's amazing.
While you were going through that, until we started to get to that point where you were doing exercise regularly, you're getting out, and even inviting, you even started saying, let's go for a hike, or let's I want to go do something this weekend. Those are things that it's good to see. It's like we've won.
I think we're thankful for Joni and Paul sharing their story, and we celebrate with them their victories and resilience in managing their health conditions. I think some of the takeaways from this story are that identity and value are tied to a person's physical abilities and their beliefs in what they can and can't do. And the PROMIS scores give us a way of documenting changes that are happening as we're listening to patients kind of tell their story and relate to us their experience of going through different rehab processes and attempting to do things independently. So the value of these scales is really in their ability to kind of help us steer what we emphasize, whether it's physical function, fatigue, or self-efficacy, as we strive to really improve their participation in social roles and activities, and therefore help them redefine their value to their family relationships, friend relationships, work relationships, and leisure pursuits. So what we're learning is that social person-centered goals are distinct from our current functional goals commonly used in physical therapy. Often patients' outcomes expectations are too low for them to express social goals that are important to them. We expect goals to change as self-efficacy, outcome expectations, and sociostructural factors are addressed as part of treatment. The PROMIS measures help us understand how treatments are influencing physical, psychological, and social domains of the patient's health. However, they do not replace social goals that are expressed by the patient during care. Before we wrap up this module, we also want to express our thanks to Terry, Paul and Joni, Jamie, and Cliff, who shared their personal stories to improve care for other patients. And that concludes this module of the Biopsychosocial Training Program.